The listening part of the occupational English test has 3 parts, and in each part, you will hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You have time to read the questions before you hear the extracts. You will hear each extract only once. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 different extracts. In each extract, a healthcare professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a neurologist talking to a new patient called Mrs. Lizaveta. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning, Mrs. Lizaveta. Could you tell me what the problem is?
I have a mild gait impairment and cognitive slowing, doctor.
What's your age?
71, doctor. I think I walk in a funny manner. Actually, my husband has noticed this over the past 3 months and says I have broadened my base and have developed stooped posture. My balance has also started declining. I have to use walls or furniture to stabilize myself. However, I'm not using any kind of assistive device.
So what about your bowel and bladder movements?
I do not have any issues, doctor. No frequency, issues, or urgency.
Do you have any headaches?
No, doctor.
Have you experienced any change or decrease in your memory or thinking?
It is not as smart as it used to be earlier. However, I am able to pay the bills. My thinking has slowed down. I often get stuck with the words when I speak.
Have you ever had any trouble with syncope or vertigo?
I don't have any trouble with syncope, but I've had some episodes of vertigo. I was diagnosed with hypertension in 2014, but no snoring or apnea.
Any other complications?
I've had arthritis since 2000 and thyroid abnormalities since 1975.
Have you had any surgery?
Well, I had a hysterectomy in 1992 and a wrist operation after I fell down in 1972 with a titanium plate and 6 screws.
All right, can you give me a brief history of any illness in your family?
My mother had colon cancer.
Are you allergic to any medicines?
Yes, codeine and sulfa.
What medications are you taking now?
Premarin, 0.625 milligrams, Acifex, 20 milligrams daily, Toprol, 50 milligrams daily, Norvasc, 5 milligrams daily, multivitamin, Caltrate plus D, B-complex vitamins, calcium and magnesium, and vitamin C daily.
Well, after reviewing all of your medical reports, I doubt that you've developed adult hydrocephalus. Your diagnosis reports show blood pressure 154/72, and your heart rate's 87, and the weight 153. And your pain is 0 out of 10. Your spine is straight and non-tender, and you have very mild kyphosis, but no scoliosis. And your gait assessment shows that you have some unsteadiness and a widened base. I've reviewed all your x-ray reports since 2009, and it shows a mild ventriculomegaly with trace expansion into the temporal horns. The Sylvian aqueduct appears to be patent. Your corpus callosum appears to be bowed and effaced. You have developed a couple of small T2 signal abnormalities, but no prominent changes in the paraventricular signal. I should have your cerebral spinal fluid leakage tested through lumbar punch method. With this test, I can assess your response to shunt surgery. There is a mild risk of meningitis of 2 to 3%.
You hear a senior obstetrician talking to a patient called Hilary Johnson, who has been referred by her midwife.
Hilary Johnson? Hi. Do come in and take a seat. I'm Dr. Smith, and I'm a senior obstetrician here. So, Hilary, you've been referred to us by your midwife. I have her notes with me here, but could you tell me in your own words why you've been referred?
Oh, yeah, no problem. I think I've been referred to you because the midwife said she found some glucose in my urine sample and was worried about diabetes. If I understand correctly, I could have diabetes during my pregnancy, but if I do, it's not likely to continue after giving birth. I've noticed that I'm craving sweets and cakes all the time at the moment, and I've just been letting myself eat whatever. So I've put on a bit of weight, and I don't think it's all just baby weight either. I've never had a problem with diabetes before, and I'm hoping it'll turn out to be something else. My aunt actually has type 2 diabetes, but she's always eaten a lot of sugar, so I think that might be a factor. She just controls hers with diet now and doesn't have to take any medication.
Oh, okay. Thanks for letting me know. I see from your notes that you're 24 weeks pregnant now. How has your pregnancy been up to now?
Oh, I have been so lucky. I got the usual sickness early on. Well, stomach pain, but not actually being sick. I think that's pretty common, and it settled after the first trimester. I've been taking some medication because I also had pretty horrible heartburn.
Right.
And it seems to take care of the problem. And also I've started to get a bit of back pain in the last week or so. I'd say it's like a throbbing feeling, but other than that, I've been pretty fortunate. I suppose I've been gradually getting more and more tired since the start of my pregnancy. I've just put it down to the extra energy my baby needs, but it could also be because I haven't been sleeping very well. Also, sometimes the nausea stops me from making something healthy for dinner, which is annoying because I know I need to eat healthily. I take a prenatal, though, to make sure I'm getting the right nutrition.
Well, it seems like you're managing to deal with most of your symptoms well.
Yeah, this is my first pregnancy, and to be honest, I didn't have a clue what to expect, but so far so good. It's only this glucose thing that's got me worried. I imagine it's just a one-off, but I guess it's best to get it seen to.
Certainly, and I'm pleased you're here so we can get things sorted. So we'll need to book another appointment to carry out some tests.
Okay, so when will I have to have this? Because I'm a bit busy at work at the minute.
Well, ideally as soon as possible. Can I ask what you do for a living?
I'm a high school teacher, and it's just getting to that time of year when the kids are gearing up for their examinations. So I can't afford to be taking too much time off during the day. I'm actually a little bit stressed at the moment as well. I've had to do a lot more work over the past few weeks. I think it's just that time of year. I've been a teacher for 4 years now, so I'm starting to develop ways of coping with the madness. With that in mind, if our next appointment could be at 5-ish or later, then that would be perfect.
No problem. Just make sure to let the receptionist know your preferences. When we find sugar in preliminary tests, we offer an oral glucose tolerance test, which is what we'll do when you come in next. Do you know what that involves?
Well, I asked a few of my friends about their pregnancies, and my friend Beth said that she had the same thing and told me about that test. She said that she had to come into the hospital and drink a sugary drink and then have a blood test to tell if she had diabetes. Is that right?
Yeah, that's pretty much it. Here's the leaflet that explains the test so that you can have a read about it when you get home. Do you have any other questions for me?
No, I don't think so. I'll go away and read this and wait and see what the test says. Well, thank you for your help today.
You're welcome. I'll see you once we have the results and we can take it from there.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at the question 25. You hear a monologue by a physician explaining to his staff about cutaneous manifestations. Now read the question. Cutaneous manifestations are the medical consequences of starvation, vomiting, abuse of drugs such as diuretics and laxatives, and of psychiatric morbidity. These manifestations include lanugo-like body hair, cirrhosis, carotenoderma, telogen effluvium, acne, seborrheic dermatitis, hyperpigmentation, acrocyanosis, petechiae, pernosis, livido reticularis, interdigital intertrigo, paronychia, generalized pruritus, acquired scurae distente, slower wound healing, prurigo pigmentosa, edema, linear arrhythmia chronique, acral coldness, pellagra, scurvy, and acrodermatitis enteropathica. The most characteristic cutaneous sign of vomiting is knuckle calluses called Russell's sign. Symptoms arising from laxative or diuretic abuse include adverse reactions to drugs. Symptoms arising from psychiatric morbidity include the consequences of self-induced trauma. Question 26. You hear a monologue by a physician explaining to his staff about symptoms of anorexia nervosa. Now read the question. Multiple studies of anorexia nervosa patients have revealed a decreased left ventricular mass, cardiac output, left ventricular index, and left ventricular diastolic and systolic dimensions. Long-standing hypovolemia has also been seen in the patients. Mitral valve motion abnormalities, including mitral valve prolapse, were also seen in a distinct minority that can cause chest pain and palpitations. But the ejection fraction seems to remain preserved in most patients. However, weight restoration had a significant impact in normalization of cardiac dimensions. Question 27. You hear a discussion between a physician and his nurse about endometriosis. Now read the question. Hello, doctor. What is endometriosis? Well, endometriosis is a disorder when the tissue that forms the lining of uterus grows outside of the uterine cavity. It is abnormal for endometrial tissue to spread beyond the pelvic region. This condition is known as an endometrial implant. The hormonal changes of the menstrual cycle impact the displaced endometrial tissue, causing the region to become painful, inflamed, and making the tissue grow thicker and finally break down. At one stage, the broken tissue has nowhere to go and becomes trapped in the pelvis. Question 28. You hear a discussion between the physician and his nurse about treating the signs of eating disorders. Now read the question. Hello, doctor. What kinds of treatment measures do you suggest for the signs caused due to eating disorders? Although skin signs of the patients with eating disorders improve as they gain weight, the dermatologist is responsible to treat the dermatological conditions as well. Antibacterials or azelaic acid is effective to treat acne, that these may be described as monotherapy or in combinations. Combination zinc with antibacterials such as erythromycin are also suggested because zinc deficiency can be a possible cause for this sign. Angular stomatitis, cheilitis, and nail fragility can be treated with topical tocopherol. Cirrhosis improves with moisturizing ointments. Ointments that contain urea are effective in decreasing the size of Russell's sign. Question 29. You hear a discussion between a physician and his junior about pain transmission. Now read the question. Hello, doctor. What is the theory of pain transmission? Well, the nerve fibers that are connected to the receptors in the skin, muscles, and organs called primary afferent axons transmits the pain signals to the brain and spinal cord. These axons of various sizes may be myelinated or unmyelinated that are classified into different groups based on their size, namely A alpha, A beta, A delta, and C nerve fibers. All of the A afferent axons fibers are myelinated, while C afferent axons fibers are unmyelinated. The thickness of a fiber determines the speedy transmission of information. According to the gate control theory of pain, the pain is a function to balance between the information traveling into the spinal cord through large and small nerve fibers. Small nerve fibers transmit nociceptive information of the pain, whereas large nerve fibers carry nociceptive information. The large and small axon nerve fibers synapse on projection neuron cells to the brain and on inhibitory interneurons within the dorsal horn of the spinal cord. The firing of the projection neuron signals pain to the brain. The inhibitory interneuron decreases the chances of the firing of the projection neuron. Question 30. You hear a discussion between a physician and his nurse about subclinical seizures. Now read the question. Hello, doctor. When do subclinical seizures occur? Well, subclinical seizures occur due to unusual electrical activity within the brain. Often, the symptoms are unnoticed, even by the patient. The only method to detect subclinical seizures is performing an electroencephalogram to measure the electrical activity of the brain. That can capture the seizure activity. At times, subclinical seizures are mistaken for the abnormal behavior of autistic patients. For instance, an autistic student showed good cognitive development in his studies last year. However, this year his progress has slowed down. Signs such as aggression or meltdowns were seen in the patient. He used to daydream and ignore others when anyone asked him anything. This condition was mistaken by his parents for autism. All such signs are often mistaken for behavioral issues linked with autism that can actually be connected with a subclinical seizure. According to findings, subclinical seizures may be the cause of psychiatric disorders or compulsive and behavioral disorders or even schizophrenic, criminal, and antisocial activities.
That is the end of Part B. Now look at Part C. Part C In this part of the test, you will hear two different extracts. In each extract, you will hear health professionals talking about specific aspects of their work. For questions from 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at the Extract 1. Extract 1, questions from 31 to 36. You hear the doctor briefing his juniors about different types of chest pain in female patients. You have 90 seconds to read the questions from 31 to 36. Chest pain is one of the common health issues from the patients in medical OPDS that causes a lot of anxiety in the patient, as it is often connected with a heart attack or angina, and people are well aware of the severe consequences of the symptom. However, a chest pain is not necessarily caused by or originating from the heart diseases. There are numerous other structures in the thoracic cavity. Therefore, a systematic approach is crucial to arrive at the correct diagnosis causing the chest pain. A chest pain in menstruating females has a great significance, as they are less liable to get heart diseases until menopause. Estrogen prevents the development of atherosclerosis. Coronary artery disease or myocardial infarction is very rare in menstruating females. As menopause approaches and estrogen levels decrease, the chances of development of coronary artery disease increases. Reversible loss of blood supply to the heart muscle called angina pectoris or cardiac pain is retrosternal, poorly localized, vague, heavy, squeezy feeling, compressive. Angina pectoris rarely lasts for less than 1 minute or more than 20 minutes. Unless it is a heart attack, patients are relieved in less than 5 minutes on the use of sublingual nitrates or cessation of all activities. Angina pain can also occur in the left arm, left shoulder, the jaws, or neck. Sudden blockage of an artery supplying blood to the heart muscle, called myocardial infarction, would be similar to this but very severe and lasts longer. The pain will not be relieved by sublingual nitrate or rest, and the symptoms are palpitations, nausea, vomiting, perspiration, blackout, dizziness, or even mortality. Pain that is unlikely to be of cardiac origin is often well localized, lancinating, prickly, sharp type lasting for less than 15 seconds at times. It can also be an aching type but mostly will be aggravated by coughing and deep inspiration. Often, the patient will be able to localize the pain with the tip of the finger. However, the pain that is localized just below the left nipple will never be from cardiac origin. Common causes of chest pain in young females. Mitral prolapse is a common and benign condition. Leaflets of the mitral valve are lengthy, redundant, and bulky. They prolapse into the left atrium during systole. The causes of this pain are unknown. The pain occurs at rest, non-radiating, prolonged in duration, and sharp. Mitral stenosis or rheumatic valve disease is a common rheumatic condition in females and can cause dyspnea and chest pain. The patient will have symptoms like expectoration, a cough, and there would be low-pitched rumbling diastolic murmur that will clinch the diagnosis. A 2D echocardiography will be confirmatory.
Now look at Extract 2. Questions 37 to 42. You hear the monologue of a physician giving a lecture on scleroderma. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain different types of scleroderma?
Well, scleroderma is a symptom of a complicated group of diseases by an abnormal growth of connected tissue that supports the skin and internal organs. This disease is also termed as systemic sclerosis. Scleroderma literally means hard skin, derived from the Greek words sclerosis, meaning hard, and derma, meaning skin. Scleroderma is considered both rheumatic disease, since the conditions are characterized by inflammation and pain in the muscles, fibrous tissues or joints, and a connective tissue disease. Certain types of scleroderma have a limited abnormal process that primarily makes the skin hard and tight. Other types are more complicated, affecting the internal organs such as the lungs, heart, and kidneys, and the blood vessels. A phrase identified as softening occurs, during which less collagen is produced. There are two main classifications of scleroderma: localized scleroderma, that affects only certain parts of the body, that includes linear scleroderma and morphea, and systemic sclerosis, that affects the entire body. Localized scleroderma. Localized scleroderma affects the skin and related tissues, and at times the muscles below. However, internal organs are not affected. Localized scleroderma can never advance to the systemic type. Moreover, localized types can improve over time. However, the skin changes that occur during the disease can be permanent. It may be serious and disabling. Morphea. Reddish patches of skin that thickens into firm oval-shaped areas are distinctive characteristics of the morphea type. The centers of the patches appear ivory with violet borders. The patches occur on the stomach, chest, face, back, legs, and arms. Typically, these patches sweat a little and have little hair growth on it. Morphea can limit to one or several patches, ranging from ½ inch to 12 inches in diameter, or else it can be hard and dark, spreading over larger areas of the body. Morphea generally fades out in about 5 years. However, people can have permanent dark skin patches and muscle weakness. Linear scleroderma, characterized by a distinctive single line or band of thickened, abnormally colored skin. Typically, the line runs down an arm or leg and can run down the forehead. Systemic sclerosis not only affects skin but also involves blood vessels and major organs. Patients with systemic sclerosis often have all of the following symptoms, known as Kress syndrome, an acronym for calcinosis, formation of calcium deposits in the connective tissue. Raynaud's phenomenon. Small blood vessels of hands or feet contract in response to cold or anxiety. Esophageal dysfunction. Impaired function of the esophagus occurs when smooth muscles in the esophagus lose normal movement. Sclerodactyly. Thick and tight skin on fingers result from deposits of excessive collagen within skin layers. Cholangiotaceous. Small red spots on the hands and face are caused by swelling of tiny blood vessels. Systemic sclerosis is further divided into two categories, called limited and diffuse. Typically, limited scleroderma has a gradual onset and is restricted to certain parts of the skin, such as hands, fingers, lower arms, face, and legs. Often, Raynaud's phenomenon is experienced for years before skin thickening becomes evident. Calcinosis and cholangiotaceous often follow. At times, limited scleroderma is referred to as Kress syndrome because of the predominance of Kress symptoms in these patients. Typically, diffuse scleroderma has a sudden onset. Skin thickening develops quickly and covers much of the body in a symmetric pattern. Most of the internal organs can be damaged. Skin can swell, appear shiny, and feel itchy and tight. The damage of diffuse scleroderma occurs over a period of a few years. After a period of 3 to 5 years, patients tend to stabilize, a phase when progression of the disease seems little and symptoms subside, but gradually. Skin changes begin again. A phase identified as softening occurs, during which less collagen is produced and the body rids of excess collagen by itself. This is the end of Part C. You now have 2 minutes to check your answers.